Hello, everyone. I am Salim Virani, and I serve as Vice Provost for Research and Professor of Medicine at the Aga Khan University in Pakistan.
And I'm Kristin Newby. I'm a professor of medicine in the Division of Cardiology and a faculty member at the Duke Clinical Research Institute at Duke University School of Medicine.
So, we are so excited today to be talking about the 2023 American Heart Association and American College of Cardiology guideline for the management of patients with chronic coronary artery disease.
For patients with chronic coronary disease, if there's an opportunity to do so, clinicians should first intensify guideline-directed medical therapy and defer testing for risk assessment. So that's one of the key principles. And why do we say defer testing? Testing is expensive. There's the possibility that we get false positive testing.
When we talk about risk, what I would say, there are four major buckets of information that we as clinicians need that will allow us to identify which of our patients is very high risk, which patient is not that high risk. And these include uh, socio-demographic variables that we all are aware of, whether that's sex, whether that's social support. Second is patients passed on concurrent medical as well as history related to mental health conditions, because we know that both medical conditions as well as mental health affects prognosis in patients with chronic coronary disease. We briefly talked about ancillary cardiac testing or imaging. That, of course, gives us some ideas about what are high risk features, which patients are going to have a high risk of cardiovascular events. And then, last but not the least, if biomarkers are measured on some of these patients, for example, high sensitivity troponins as well as B in the outpatient setting, these biomarkers can also be helpful when we are doing risk stratification in these patients. When we are evaluating these patients in the outpatient setting, we should get a pretty good sense whether we are dealing with a low risk patient, an intermediate risk patient, or high risk patient. And this risk stratification is extremely important because we have a lot of options in terms of therapies that we can use in these patients with CCD. So knowing which of our patients with chronic coronary disease are low risk, intermediate risk, or high risk will allow us to intensify those therapies and maximize the benefit of those therapies. And then the third aspect of this is that there are some patients with chronic coronary disease or suspected chronic coronary disease where it might be important to perform a coronary angiography to assess coronary anatomy for risk stratification purposes. These include patients with newly reduced LV systolic function, those who have clinical heart failure, or both. At the same time, what our listeners will notice that there is a class 3 recommendation that there is no benefit of using coronary angiography for risk stratification routinely